Hello and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Hudspeth, and I'm the radio program manager for MS Focus Radio. And I'm joined by Dr. Scott Silliman, who will be talking to us about highlights of the 2020 ECTRIMS, ACTRIMS treatment and research findings. After the presentation, we'll open it up for your questions and comments. Dr. Silliman is the director of the Comprehensive Multiple Sclerosis Center, which he founded in 2013. He is also director of the Comprehensive Stroke Program and the Neurology Residence Program at UF Health Jacksonville, Department of Neurology. His background is medical school. He went to Albany Medical College in Albany, New York. His residency was at Albert Einstein College of Medicine in Bronx, New York, and his fellowship was at Vascular Neurology, Spaulding Medical Center at Tufts University. Dr. Silliman is a principal investigator in numerous research trials in multiple sclerosis. Many have brought medication to FDA approval for treatment. He's a nationally renowned expert in the field of both stroke and multiple sclerosis. Dr. Silliman has numerous publications and has been a professor in the Department of Neurology for 23 years. He's an avid fan of the New York Yankees and Jacksonville Jaguars. We're pleased to have him join us today to present this important topic. Dr. Silliman, thank you so much for being with us, and I'll turn it over to you.
Well, thank you for that introduction and welcome everyone. I've been looking forward to doing this, and yes, I did grow up in the New York City area. I'm a Yankee fan. I'm in Jacksonville. There are a lot of Tampa Bay Ray fans here, so I'm getting my lowdown here, but I'm going to root for the Rays for the rest of the way here. It's always good to root for the underdog, shall we say. So the timing of this talk was purposeful. I plan on spending the next 40 to 45 minutes reviewing the important updates from the ECTRIMS, ACTRIMS meeting, and I'll save time for questions. So please feel free to write down any questions as I move along, and we'll have time for questions at the end of the talk. So let's just talk a little bit about what ECTRIMS and what ACTRIMS are and what this meeting was. So ACTRIMS stands for the Americas Committee for Treatment and Research in MS. So this is a society comprised of scientists, physicians, and people who work within the pharmaceutical industry who have scientific and clinical interest within the field of multiple sclerosis. The ACTRIMS component is focused on North America and South America. It is a society that was founded in 1995. ECTRIMS is the sister society comprising the European countries. Every 3 years, ACTRIMS and ECTRIMS join together to hold an international symposium that is focused on cutting-edge research as well as new treatment paradigms in the field of MS, and it is clearly at the pinnacle of all meetings held throughout the world on MS. This year, I was scheduled to go to Washington to see it live, as it was held, the week after, or just after Labor Day, which was late this year. Because of the pandemic, the meeting was shifted to a virtual conference. And for those with MS in on this call, I want to let you know that the universe of people with an interest in finding better ways to treat MS is expanding. There were nearly 4,000 scientists and physicians and representatives from industry who attended this conference. So it's a big conference. Let's just look, why do the Europeans and Americans get together every 3 years for this conference? By the way, the ACTRIMS committee gets together every year and ECTRIMS gets together every year. It's just every 3 years they merge. So when we look at the prevalence of multiple sclerosis, the prevalence of multiple sclerosis is very similar in Europe as it is in the United States. There was an interesting publication just over a year ago, published in a major journal called Neurology, that looked at insurance claims, and it actually doubled the estimate of the prevalence of multiple sclerosis in the United States. So these numbers are based on per 100,000 people. The estimate for the United States is now at 309 per 100,000. So I live in Jacksonville, Florida. Jacksonville, Florida is, I think now we're the 12th largest city in the United States with about 900,000 people. So that would equate to about, roughly 2,700 people just within the city of Jacksonville who have multiple sclerosis. Notice that the numbers in Canada are very similar. And when we look at Europe, the numbers approach the numbers that we see in Canada in certain areas. And the prevalence is still very high in other countries. One thing to illustrate here on the map of the United States, I think many of you are familiar with the so-called north-south gradient of the prevalence of multiple sclerosis, whereby people who live in northern climates have a higher risk of developing MS as compared to those in more southern reaches. And this is a table from that paper published in 2019 looking at insurance claims. And it did seem even within that study utilizing insurance claims in the United States, there was a higher frequency of MS with north to south, with the highest frequency being in the Northeast, nearly 100 per 100,000. In Europe, we see that same phenomenon with areas like Ireland and Scotland having a higher frequency than more Mediterranean type of countries such as Italy and France. So in both Europe and the United States and Canada, and even in parts of South America, MS remains a public health issue that's very important to all. So I'm going to cover two main topics. Nearly half of the meeting, there was actually a special session, maybe not a half, but about a third of the meeting was devoted to COVID-19 and MS. We'll cover some topics about are MS patients at higher risk for developing COVID-19? If they develop COVID-19, are they at a higher risk for severe infections? Does utilization of immune modulating therapies alter the risk of developing a COVID-19 infection? These are questions that I get from my patients, and our team here gets questions all the time from our patients about whether or not they should temporarily stop their disease-modifying therapy. Should they alter the dose of it? So we'll cover some things here which I think are reassuring. And then, up until recently, both primary and progressive MS and secondary progressive MS were I don't want to say ignored, but they were under-recognized as types of MS to be studied in clinical trials. There were a couple of interesting presentations looking at new agents and new methods of potentially treating progressive MS. So I'll cover that component as well. So let's start off by talking about COVID-19 infections. And these are the numbers in the United States as of this past weekend. Current numbers reflect that we have about 7,750,000 Americans who have been infected by the virus, and that has contributed to 214,000 deaths. Now, keep this number in mind. This is the case fatality rate for COVID-19, about 2.75%. If you like to round off numbers, about 3%. So 3% of Americans who have been infected with COVID have had a fatality related to the infection. And the hospitalization rate has varied over time. I think we know that hospitalization rates were very high very early on. And then there was a second wave in July. Our wave here in Jacksonville for hospitalization was actually higher in July through early August than it was early on with the infection. But hospitalization rates have ranged from roughly 2.5% to 10%. But keep this number in mind, the 2.76% number in mind. So I'm going to share some experiences. As time has gone on, this meeting was really timed perfectly for people to share their experiences with respect to databases that are looking at the frequency of COVID-19 infections in people with MS and what the impact of COVID-19 has been on people with MS. Remember that the first cases in Europe were really reported in early February. So this meeting occurred approximately 7 months after the first reports in Italy. I'm sorry, in Europe. I'm going to share several countries' experiences. And the Italians were hit very hard early on as a country. And they actually published their experience. They were the first country to publish their experience. This was published pre-meeting in April of 2020. The database was comprised of case reports that were sent to a central registry area by just over 200 Italian neurologists that practiced at 90 MS centers across Italy. So they were sending in these reports as they came across patients with COVID-19. Now, patients in this database, not all had confirmed COVID-19 infections by PCR tests or nasal swabs, but they did include patients who had typical symptoms of COVID-19 and may have not been tested. In other words, people who may have lost their sense of smell and taste and had a pneumonia. So this database was comprised of 232 patients. About 40% of the centers reported data. Most cases were negative, but strongly still negative with official, of those tested, many of them had a negative test, but as we know, the tests are not foolproof, and it was felt that these patients still had symptoms consistent with COVID-19. Now, this is the good news. The vast majority of patients had a very mild infection and did not require hospitalization. 6 patients had a severe infection. Of those, 5 unfortunately passed away from the infection, which amounts to 2.2% in their database. And as I mentioned earlier, that's very similar to the American number in the general population. The author said that these results appear to be reassuring, not reassuring in the fact that people with MS do get COVID, but the numbers were very similar to those in the general Italian population. The French did report their experience at the ECTRIMS meeting last month, and they had 405 patients with MS. This is a typo here. They had 405 patients within their database. Many of these patients were on immune modulating agents, and I think, as you know, some of the immune modulating agents that we utilize, like some of the oral drugs like Tecfidera, Vumerity, Gilenya, and certainly some of the IV drugs we use, or the IV drug that we use, Ocrevus, can lower lymphocyte counts. Nearly a third of patients in the study had lymphopenia, or a reduction in white cells that we can see in association with these drugs. But the good news here was that the death rate was 3%. Very similar to the Italians, very similar to what's been reported in the United States. Now, in terms of risk factors that were associated with a higher frequency of dying from COVID, it's very similar to what one might expect. We know that older people are more susceptible to severe infection, and patients with various medical comorbidities, and people with debilitating diseases that lead to physical dysfunction are also more prone to having severe infections. So in the French cohort, they did find that increasing age and increasing levels of disability were associated with a higher risk of having a severe infection. Now, in this study, they were able to look at the medications that patients were on, and they did not find an association with any medication increasing the risk of severity or death, which is good news, despite the fact that 30% of patients had a low lymphocyte count. What was interesting is that there was, in this study, no hospitalization for any patient on an interferon or glutarimer acetate. Now, it may not be the fact that these drugs are more benign in the setting of COVID, but remember, in Europe, in France, because France has a socialized system of medicine, it may be in part that there's more step therapy going on. People have to be on an injectable and fail that before they go to an oral, before they go to an IV infusion. So these patients may have been younger and also had a lower level of disability. Now, as a sidebar, I'm going to take a sidebar here. This is interesting, interferons. So interferons, some of you, or certainly you may know people that were treated, or you still may be treated with an interferon. The three current interferons on the market are beta-seron, Avonex, and Rebif, and they're all injectables under the skin. Interferon is a protein that was discovered in the 1950s, and what interferons are, they're proteins that all of our bodies have that immune cells create to talk to each other, particularly when there's a viral infection. And the word interferon actually comes from the fact that in the 50s and early 60s, when scientists were first working with interferons, they discovered that interferons interfere is in here, with viral replication. All right, so the thought here is, could interferons actually reduce the risk of having a severe COVID-19 infection if someone contracts COVID-19? And currently, our National Institute of Health is funding 2 trials that are looking at whether or not an interferon can help treat patients who are hospitalized with COVID-19. So in both trials, patients who are hospitalized with COVID-19, obviously these are going to be more severe infections, they're receiving a combination of remdesivir, that is the antiviral medication that is being utilized in hospitalized patients, plus Rebif. It's a subcutaneous injection administered every other day, and they receive 4 doses of that. So every patient in this study is receiving remdesivir, and half of the patients are receiving a placebo injection, and half of the patients are receiving Rebif every other day for 4 doses. So as a sidebar, interferon beta, this was an interesting observation in the French cohort, could eventually be a treatment in patients who are hospitalized with COVID-19. The British experience, Britain has a very, has a socialized medicine system, so it's much easier to do registries in that type of setting. And the UK MS registry is comprised of 18,000 patients with MS. And within that registry, through ACTRIMS and ECTRIMS, this was presented, there were 535 patients who reported having a diagnosis of COVID. Now look at this. This lists the medicines that are used in Britain. Pretty much all of these are used here in the United States. They did not find that any of these medications were associated with a higher risk of contracting COVID-19. In other words, patients on Lemtrada were not higher than patients on interferons, or Gilenya was not associated with a higher risk than Tecfidera. And they compared this to patients who were not on an immune modifying drug. So there are, I can't recall the percentage of patients in here who were not taking an immune modifying drug, but if we look at this straight line here, this straight line is indicative of not being on an immune modulating agent, and all the lines cross over that. So the scientists here that are overlooking this registry do not see an association with any of these drugs being associated with a higher risk of COVID-19 injections, of COVID-19 infections. So again, good news, supporting the fact that the DMTs, no specific DMT was associated with a higher risk of contracting COVID-19. And it did not appear to be higher in MS patients compared with those not on a DMT. Now, what about the North American experience? This was presented actually just post ACTRIMS, and ECTRIMS is the American Neurology Association meeting, and this was just presented, I think, a week or two, looking at a registry comprised of North American patients with MS. And they analyzed in this study the risk factors for hospitalization and the need for ICU care. And patients were entered into this registry between April 1st and September 7th, so very contemporary. And as of September 7th, the registry included nearly 1,000 people with MS. The majority of the patients were women, but that's natural with MS. MS is a female predominant disease. It was a combination of patients with relapsing remitting MS, secondary progressive, and primary progressive MS. About 80% of the patients were on drugs, DMTs, disease-modifying therapies at the time of the infection. Hospitalizations occurred in 200 of these patients, with 73 requiring ICU care and 50 needed a ventilator. Now don't panic, this looks like a high percent. That's nearly 20% of patients requiring hospitalization. But this study is subject to what we call referral biases. The neurologists that were submitting this information were only in contact with patients at their routine follow-up, or if patients were sick, they would call the neurologist. So the patients that are doing well are not going to call in, and they're not going to be entered into this registry. Factors that were associated with hospitalization are what we would expect: older age, progressive disease, because patients with progressive disease tend to have more disability, and other medical diseases that we typically see in patients that are hospitalized with COVID: heart disease, history of stroke, chronic kidney disease, COPD, or chronic lung disease, diabetes, and morbid obesity. Similar findings were seen in patients requiring ICU care. They did not observe here in North America any increased odds for COVID-19 related death with the use of any particular disease-modifying therapy. And the authors concluded that COVID-19 among patients with MS is like its impact in the general population. In other words, patients with MS who are hospitalized tended to have other medical comorbidities. And also reassuringly, just as I mentioned with the British cohort, the data from North America so far is not showing a marked increase in severe COVID-19 disease with MS disease-modifying therapy. And with all these data sets from different countries, their data will continue to be entered over the ensuing months, and I'm sure that you'll see more reports coming out. The next big meeting to pay attention to is probably in March or April, which is the American Academy of Neurology meeting. Although it has American in there, it's truly an international society, and we'll probably see 6-month follow-up data presented at that meeting. Other COVID-19 vaccine, COVID-19 in the news is the vaccine trial. That there are multiple vaccine trials going on, but I think that you probably heard about one trial being halted in September. AstraZeneca is a pharmaceutical company that is exploring a vaccine, and the trial was halted when a patient in Great Britain developed what we call transverse myelitis. So this is an MRI of the cervical spine here. Transverse myelitis, the word transverse implies all across. Transverse myelitis is an autoimmune reaction, typically to a foreign protein, and it can occur after certain vaccinations. What happens is the vaccine is comprised of proteins, and in some of us, for genetic reasons, the insulation or the myelin on the millions of nerves of the spinal cord can resemble some of the protein combinations found on the viral surface. So the vaccine is administered. It's hunting out protein sequences that look like the viral sequence, and in patients who genetically have that sequence naturally within the myelin on the spinal cord, they'll get an attack. And you can see here in this patient, this is just an example of transverse myelitis. The white here represents inflammation, and it's very long and involves 1, 2, 3, 4, 5, 6, 7, 8, almost 9 vertebral body lengths here. And typically when we give the gadolinium, it's very inflamed. It's treated with steroids or sometimes plasmapheresis, where we extract the abnormal antibodies out of the blood. So one patient in the AstraZeneca trial had a bout of transverse myelitis. Now this looks very different than an MS lesion in the spinal cord. MS lesions tend to be smaller. This is a cervical spine MRI. You can see this little round marble-like white spot in the spinal cord, one here, and this is in the thoracic spinal cord as well. Now, interestingly, in a volunteer in an earlier phase of that trial experienced a similar side effect, but the investigators found out that this person had multiple sclerosis that was unrelated to the vaccine. So it wasn't a case of transverse myelitis in July. It was probably an MS patient who had an MS exacerbation in the trial. And the investigators felt that the vaccine was not causative. So in the AstraZeneca trial, we do have one case of transverse myelitis in a patient without MS, and we do have one MS exacerbation in a patient who had MS. Now, because of this case of transverse myelitis, the AstraZeneca trial is on hold in the United States, pending review by the FDA, but it has resumed in other countries as listed here. So in brief summary, the good news about there's no good news about the COVID-19 pandemic by any means, but I think the take-home message briefly is that it does not appear that patients with MS are at a higher risk of contracting COVID-19, whether or not they're on a DMT. And it doesn't appear that patients with MS, whether or not they're on a DMT, are at a higher risk for having a severe infection. In other words, one requiring death, one requiring hospitalization, or one requiring ventilation. And it does not appear that the frequency of death is higher in patients with MS. Now, that doesn't mean go out and take your mask off and not wash your hands. It still is very, very important to adhere to the guidelines with reference to minimizing the risk of contracting the virus. So it's reassuring. We have counseled our patients not to discontinue their disease-modifying therapies. We had a lot of phone calls early on about that, and I think the data at hand so far supports that recommendation from myself as well as other physicians who manage patients with multiple sclerosis. I want to move into progressive MS, and I think the two most interesting presentations were focused on these two novel medications. When I talk about progressive MS, there are really two forms of progressive MS. There is what we call primary progressive MS, and then there's secondary progressive MS. Most patients with multiple sclerosis have a relapsing or inflammatory course where they have relapses that come periodically. There are some patients with relapsing MS who later on in their disease course tend to develop a progressive component to their disease where the relapses become less frequent and there's more of a steady decline in their neurological function. If we look at the neural imaging on those patients, typically in patients with relapsing MS, we tend to see inflammation in the brain with gadolinium, whereas when they develop this secondary progressive form, we're less likely to see inflammation in the brain. About 10% of patients with multiple sclerosis have primary progressive forms of MS, where it's, rather than having relapses, there is a steady decline in neurological function over the years. And again, in these patients, their MRIs tend to lack gadolinium enhancement. Now, up until recently, there has been no treatment for primary progressive MS. Several years ago, just a few years ago, Ocrevus was approved for primary progressive MS. Many of the drugs that we have now are approved for what we call active secondary progressive MS. Active secondary progressive MS implies that patients are having some gadolinium enhancement and maybe some relapses despite having a secondary progressive course. But we really, we need better drugs, not necessarily better drugs, we need more drugs to choose from in our patients with progressive MS. And I want to just talk about these two medications, which were presented, and share some of the information regarding those two medications. So we're going to talk first about Mastini. White cells are a family of cells found in our blood that play a role in fighting infections. I think, as most of you know, there are one type of white cell called the lymphocyte is responsible for the attacks in MS, but there's a multitude of different kinds of white cells in our bloodstream. One type of white cell is called the mast cell, and the mast cell is a white cell that is rich in something called histamine. We can buy over-the-counter antihistamines. Histamines play a role in allergic reactions. They play a role in when we have an infection. These white cells release histamine. And think about when we have an allergic reaction, these white cells also release histamine. What happens when histamine levels go up in our body? Our blood vessels dilate. All right, our blood vessels dilate, and the blood vessels in our noses dilate, and we get a runny nose. The blood vessels, sometimes if you think like about a conjunctivitis, for instance, and histamine's released in the sclera there, you get your eyes tear. Our throat feels a little bit inflamed too from release of histamine in the throat blood vessels. There's extra fluid being released there, and that's because the blood vessels are dilating, they're expanding, and the cells that comprise the blood vessels, because the blood vessels are expanding and stretching, the cells get a little bit further apart so fluid can leak through them. All right. Now this drug Mastini inhibits a specific enzyme that's found in mast cells, and it's a specific enzyme that is sort of important for them to live a long and prosperous, these mast cells to live a long and prosperous life. Now think about what I just said. When we have an allergy and blood vessels dilate and fluid leaks through, we get our runny nose, our scratchy eyes, and our sore throat. There is some evidence that mast cells may play a role in MS. So mast cells, when they release histamine in the brain, in the blood vessels in the brain, may allow the blood-brain barrier to break down enough to allow these hungry T cells to leak through. So it's almost as if the room I'm in here, is a blood vessel. And if I had a spray bottle that was a mast cell, I do have a spray bottle here, and I sprayed it. There's some histamine, and it's actually just hand sanitizer. And I sprayed some histamine and the door opened, and I'm a T cell. I could leak out into the brain and go chew on some myelin. Now, what if the mast cell is taken away? Well, perhaps the blood-brain barrier isn't as leaky, and the hungry T cells can't leak into the brain. So this is the concept here is that if we can diminish mast cell survival, perhaps the T cells can't get into the brain as frequently or in the same amount that they normally can. Now, as a side note, Mastini has been used in veterinary medicine since 2008 for animals, particularly dogs with mast cell tumors. And in thinking back, I actually had a Sheltie that unfortunately passed away from mast cell tumors. They typically manifest sort of as lumpy, bumpy skin. They start off in the skin, and they can metastasize to the stomach and other organs. But I think we had my Sheltie 10 years ago back on this drug, if I remember correctly. This is just for informational purposes. In research, we tend to measure what's called the EDSS, the Expanded Disability Scale Score, and it ranges from 0, which is no deficits, up to 9, which is confined to bed. And typically when people have an EDSS of 6, they require a walking device, a cane or some other device to help them with their walking. I'm going to refer a little bit to the EDSS here, just so you're familiar with this scale. Now, the MasterNAV trial was presented at ECTRIMS, and this is not a phase 3 study, so this is not one that will lead to FDA approval, but this is an exploratory, what we call phase 2 study, looking primarily at safety and also trying to figure out the best dose for this drug. What was nice about this study is it had an upper age limit of 75. Too often in clinical studies of MS, people over the age of 50 have been ignored. And to get into the study, patients had to have had an EDSS of 2 to 6. So that's from minimal disability up to assistance required to walk. And they tested 2 doses. It was a pill given each day, and they measured the outcome at 96 weeks. And the primary endpoint, because these were patients with progressive MS, either primary progressive or secondary progressive MS, and I said non-active here. By that I mean we're not having relapses. There was no gadolinium enhancement. So these are purely progressive patients. And if you're doing a study in progressive patients, you want to, your primary outcome is going to be how much does this change? You would hypothesize if the drug's going to work, there's going to be less people going from 3 to 4 over time in active drug versus placebo. So we use the EDSS as the main scale for measurement. And basically the study was positive. If we look at the whole group as a whole, the entire cohort as a whole, the EDSS changed very little in patients on the drug, virtually a standstill, whereas it went up by 1/10 of a point in the placebo group. If we look just purely at the percent of patients with no increase in the EDSS, nearly 40% of patients in the MasterNAV arm were less likely to have an increase in their EDSS. And you can also look at this as time to progression, and patients on the active drug had a longer time to progress than those on the placebo. So in these studies, we want to be sure that drugs are safe. Now, don't get frightened by this. It says 95% of people experienced at least one adverse event, but that really wasn't different than the placebo arm. I've been involved in clinical trials, and anything gets reported, anything just to be safe. So if I have 2 days of an allergic cough. Usually something as benign as that will, from an allergy will get reported. Common side effects, though, which were a little bit, there was a non-emergent adverse effect. There were a few patients that had rash, nausea, and diarrhea, but it was not universal. They found that the adverse events were reversible and manageable. And as I mentioned, they looked at 2 doses. The lower dose was as good as the high dose. So it looks like this will be the dose that will be tested in the future, perhaps in a phase 3 study. So the conclusion from this study, this is the first-in-class type drug. It's an oral tyrosine kinase inhibitor for the scientists out there. It inhibits mast cells from proliferating. So it really is a strong antihistamine, I guess you could say. It led to significant improvements in the expanded disability scale status for patients with MS. It led to reduced time to disability progression for patients with both primary progressive MS and secondary progressive MS. And the authors concluded here that, the results were strong enough to move into a higher level clinical trial, and it may provide a new treatment option for primary progressive MS and also non-active secondary progressive MS. So just an interesting drug, an interesting mechanism of action, something that hasn't been looked at before, but a ray of hope for those with primary progressive, and particularly those with secondary progressive MS that's not active. Let's shift gears here, and here was another very interesting presentation that was focused on EpsteinBarr virus. I think we all know that for years researchers have believed that there could be a link between Epstein-Barr virus and multiple sclerosis, but to this point in time we've had a hard time finding a precise mechanism or a precise association, and it's difficult to prove because nearly 90% of all adults have been exposed to Epstein-Barr virus. Now, I'm going to show you a study here, and just the rationale behind this study is the question of whether or not Epstein-Barr, chronic Epstein-Barr infection in certain white cells in our body could drive the activation of genes in those white cells to induce the damage that we see in MS. So this is a targeted therapy. This is a kind of an interesting way of treating a disease, and the compound is called ATA188. It is extracted from the blood of people who are Epstein-Barr virus positive. They've been exposed to Epstein-Barr virus. And this protein is exposed then to what we call T cells. T cells are a type of white cell that likes to chew on things. It probably does play a role in MS. But what they're doing here is generating T cells that recognize Epstein-Barr virus infected cells and rid the body of them. So they're extracting this protein from patients that are Epstein-Barr, or this protein from people that are Epstein-Barr virus positive. Then they expose that protein to T cells, and the T cells kind of don't like it, and they get turned on, and these T cells are then infused into patients with MS, with progressive forms in this study. So it was looking at how well these activated T cells that are heat-seeking missiles for Epstein-Barr virus in our body may influence the outcome from progressive MS. So patients in this study were treated with 2 IV cycles, and there was a 1-year follow-up period. This was a phase 1 study, so really what they were trying to do is just be sure it was safe, and they tested 4 different doses. they did find it to be safe across all 4 dosage tiers and felt that the safety was good enough to allow it to continue testing into a randomized clinical trial. Efficacy in these studies, in other words, the effectiveness of the agent is always a secondary outcome. But in these patients with primary progressive MS, patients who took the higher doses were more likely to have an improvement on their EDSS that we talked about before, and also to walk a little bit more quickly than at baseline. There was also an improvement in patients on their sense of fatigue and their own personal sense of how well they're functioning in the home and the community. So this is an interesting approach, sort of targeting, in some of us, probably EpsteinBarr virus continues to live in our B cells. B cells are a white cell that during the active infection of Epstein-Barr, they infect and they proliferate. And as our body clears Epstein-Barr virus, in some of us, it probably continues to hide out in our B cells. But this drug is a way of priming T cells to recognize those infected, chronically infected B cells and ridding them from the body. So I'm going to stop there because I want to leave some time for questions. At ACTRIMS, and there were a few other kind of studies that I talked about that had been published or discussed around the ACTRIMS meeting. National databases have suggested that for those patients with MS, the risk of contracting COVID-19 appears to be similar to that of the general population. Across databases, there's no clear trend that specific disease-modifying therapies are associated with a higher risk of contracting COVID-19. And across databases, there's no clear trend that specific disease-modifying therapies are associated with a higher risk of hospitalization or death. So stay on your DMTs. Progressive forms of MS are receiving more attention in the clinical trial world. And I think we talked about 2 unique drugs for progressive forms of MS that showed encouraging early clinical trial results. We talked about sort of a new type of antihistamine, Mastini, and we talked about a heat-seeking type of missile for infected, Epstein-Barr infected B cells called ATA188. So I'll stop there, and I'm happy to take any questions.
All right, so thank you so much, Dr. Silliman. It's time for Q&A, and if you have a question or comment, please make sure to use the raise your hand feature in the app or send your question via chat. To raise your hand, click the screen to pull up the menu, select more, it's the icon with the 3 dots, and click raise hand. I will unmute you, then a button will appear on your screen asking if you want to allow me to do that, and then you select allow. So far there aren't any, we'll just wait a couple minutes for some questions. One thing that came up, Dr. Silliman, we were speaking a little bit before the conference began, and that is some people are having difficulty getting their medications because of one reason or another, delivery systems. How, if someone, what suggestion might you have for people who are having a tough time getting medication that they need and might not have a backup?
Yeah, well, there's a couple ways of going about that. One is we tend to be very proactive with our patients at visits and educate them on the fact that if they feel like things are starting to get delayed, is to call us immediately. Because we're a comprehensive center, we do have people in place, including PharmDs and also our MS program coordinator who can search it out and make a call from a higher level. So I think that's important, is be proactive about it. The other thing too is that there are sometimes ways that some of these companies can provide samples in the interim, should there be a delay in receipt. Contacting the manufacturer directly sometimes, and getting involved with the representative covering that area. Sometimes they can link up with the physician and provide samples, or until the receipt of the medication. So that's another mechanism, is going directly to the company themselves.
And a follow-up question for ACTRIMS and ECTRIMS: are there any resources online that people from the MS community can go to see some of what happened during the conference this year, like on YouTube or things like that?
Yeah, there are. Usually if you just type in your browser ACTRIMS, I always mix it up, but A goes before E, so it's ACTRIMS-ECTRIMS. There's a variety of places. One good one is called Medscape. Another one is Helio. There are some places that cover medical conferences focused on multiple sclerosis. As I mentioned too, you may want to, the next big meeting, if you want to be proactive, if you go to the American Academy of Neurology website, that is a huge international meeting. That will be in April, I believe. So that's when the next big announcements are likely to come out. The other website that you can always look at too is for real cutting edge. I know you've heard of the New England Journal of Medicine, which is certainly the premier medical journal in the world. But you can look at their website, and any new, I've seen an incredible trend in the last 3, 4, 5 years where the major MS trials are getting published within the New England Journal of Medicine. Within the medical community, MS has reached a level of interest whereby the New England Journal of Medicine, because it has an international audience, is actually publishing articles, maybe even before the results are announced. So you can just peruse through that. That's published every week. It's I think it's www.nejm.org. You may not have access to the articles, but you'll have access to the abstracts. They're a little bit medical, but I think you can get the gist of them, and you'll see a breakdown of those articles in a little bit more easier fashion on the web, throughout the web within a few days after that.
All right. Thank you very much for that. Again, if you have a question or a comment, please submit it via chat or the raise your hand feature in the app. And then I'll unmute you, and once you see the unmute, then select me, allow me to unmute you, select allow. All right, we have a question coming in from Kay via group chat. Her question is: CD4 and CD8 counts under 200 since second dose of Lemtrada. Can I still get shingles vaccine? And how does COVID affect vaccines, since folks are getting shingles with COVID now? She knows 4 people, she said.
Yeah, I mean, that's a great question. I mean, in the context of a vaccination, I usually recommend discussing that with your treating neurologist and or your primary care doctor. With traditional vaccines, if B cell counts are down, people may not quite respond as effectively as normal, although people will still respond to vaccines. Even with Lemtrada, there's still some cells hiding out in the body that can respond to vaccines. But one interesting question is that coming up, and I didn't cover it, but certainly with this question, is in patients with MS on DMTs, how are we going to vaccinate them? All right. And it really depends on what kind of vaccine is made. There are some vaccines that are more T-cell oriented and some that are more B-cell stimulating. I think the jury is still out. We're going to have to wait and see how the vaccine works. But the good news with any vaccine is that we can measure response to vaccine. You know, we can measure, you know, for instance, you know, in somebody that's had measles as a child, or now, you know, all kids are immunized against measles. You know, we've all been, I was thinking of chicken pox, I'm sorry. You know, I had chicken pox as a child, but most kids now are immunized against chicken pox. We can measure vaccine responses to chicken pox. We can measure vaccine responses to measles, and decipher whether or not somebody needs a booster. There is a possibility that some people on certain disease-modifying therapies may need boosters more than the general population, but more to come on that. There are already there's already discussions going on regarding these things based on theoretical plausibilities about how vaccines will work. But I can tell you that I participated in some discussions between industry and physicians interested in MS. But the vaccine story is probably, and I'm sure people with MS are probably, especially if they're on DMTs, will probably be on the list of, you know, the highest priority, among the highest priorities to get vaccinated in our country. But this will come with some guidance, I'm sure, in terms of the regimen.
All right. Well, we don't have any other questions, and we're right up against our time. So I'd like to thank you for joining us today, Dr. Silliman. And that is all the time we have for now. If you missed any part of the conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page and our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference is going to be Thursday, October 15th at 7:30 p.m. Eastern Time with Sean Feliciano, patient and MS advocate, on the topic of being visible despite MS. Our sincere thanks for all the attendees and your participation, and especially to you, Dr. Silliman. Thank you so much. Any final thoughts?
No, I think just stay educated. It's you know, keep reading, stay informed. That's power to you.
All right. Well, thank you very much for your time. We appreciate it, and we'll see you again soon. Thank you, everyone.
Thank you.
Bye-bye.